Hello everybody, I'm going to start the PFT workshop session, so if you don't want to be here, you may leave. Thank you. You're all so far away and you're behind a bright light. I actually often teach PFTs with pieces of paper, but I thought that I would do this not that way, which turns out is good for those people who are back there. Not connected, slides not connected. Do we need Zachary's help? Is that who we need, Liz? Thank you, Zachary. Getting your steps in, it's good for you. It's like pulmonary rehab.
I don't see that you're connected on my end, so.
What did you say? Sometimes it does.
I don't think that the laptop is connected.
If need be, I can switch back to the laptop. Oh, look at you.
I think the other laptop might be good. I don't know if it's this dongle. Is this your guys's?
It's my dongle.
I'm not sure if it's that. Sometimes these multi-ones tend to give trouble.
Let's just try it in the other one.
I have a separate one.
Okay.
That I can grab too.
Sure.
Real quick.
Yep.
So here we go.
Okay, so the first question, sure. I wanted to know why you're here. It's kind of a small group, but I did a multiple choice question for you. So I would love to know, do any of you interpret spirometry in your clinic? That's a no. Do any of you have spirometry available in your clinic? Also a no. So my other thoughts were that you might want to understand why the pulmonologists say the things they say. Okay. My last suggestion was you want to keep up with changes to PFT interpretation. And there's still some people who didn't do any of those, so I'm intrigued. Nope. Do we need to go back to the other laptop? That's fine. Okay. I don't know where it is, though. Liz, I think Liz took it.
Is this a Mac?
This is a Mac.
I don't think it's like in your laptop.
Okay. If Liz, I don't know where Liz took the laptop. Okay. I don't have a thumb drive with me. They have my presentation on there. I'm so sorry, everybody. I don't know if you're able to find Liz. Thank you. Thank you, Zachary. I know that's probably not your job. I'm going to keep going for what I can. Well, this is really painful now. So we were asked to use Poll Everywhere, and I spent an hour creating Poll Everywhere slides, and now the Poll Everywhere slide won't respond to anything and won't close. And now I'm getting stuck. I'm so sorry, everybody. Okay. So with this presentation, which at some point I will show to you, we're going to talk about using Z-scores. So that's one of the big changes that has happened. The thing you should grab onto is that you are used to Z-scores. DEXA scans have used Z-scores forever, so it's a similar idea. We're going to talk about different methods for diagnosing obstruction. Are you somebody who knows where Liz is? Yes. Because I need the other laptop back. Thank you. We're going to talk about what is the criterion for a significant bronchodilator response, 10%, I told you that already. We're going to talk about pulmonary restriction and the causes of that, and then also something called the non-specific pattern, which you can see on PFTs, which you may never have heard of. Anyone heard of the non-specific pattern? Great, we're on the learning edge, that's what I was hoping for. I've also included a section talking about the benefits and downsides of using race neutral as opposed to race specific equations. That is something that only applies to spirometry, not the rest of PFTs. Great. When you get, like, if you get my slides from somewhere, you'll see that I show you the paper that I'm going to use for a lot of this. I heard the sound of something dropping. I don't know what it was. Great, we're getting there. Okay, wonderful. Thank you, Zachary. Thank you so much. We've done that. We've talked about that. Okay, we're going to start by talking about the alphabet soup of PFTs. I think this is your dongle, Zachary. Grab it at the end. So at the top of this, I've listed the alphabet soup that you really should know about, and then these ones are abbreviations that the pulmonary fellows need to learn. So hopefully you are familiar with all of these. Residual volume down here cannot be measured by spirometry. We need to do lung volumes in order to measure, well, calculate the residual volume. When we do lung volumes, we actually measure the FRC, the functional residual capacity. It doesn't matter what method we use for doing lung volumes, be it plethysmography, which uses a body box, or nitrogen washout. I'm just saying those things because you will see those terms on PFTs. What we do is we measure the functional residual capacity, and we have the patient do a spirometric maneuver. And to calculate TLC, we add the inspiratory capacity to the FRC. To calculate RV, we subtract the ERV from the FRC. The point of sharing that with you is that the more calculations you do, the more error gets introduced. Also, people could do a good FRC maneuver, and in fact, that's part of why we use something called plethysmography. It's super simple. Most people can't mess it up, but people do mess up spirometric maneuvers. I want to point out that the vital capacity, often in PFTs, it has a letter before it, like F for forced vital capacity. A forced spirometric maneuver is what is sort of the most common PFT maneuver. It's the one that we use to get the forced expiratory volume in 1 second and the forced vital capacity. But a vital capacity does not have to be performed in a forced fashion. It could be a slow vital capacity, SVC. It could be an inspiratory or an expiratory vital capacity. Forced and slow are the main things you'll see. Okay, we're going to use, when we get to our questions, we'll just continue using show of hands. I thought I would start by showing you a normal set of PFTs and describe to you my approach to reviewing PFTs. So first I look at the graphics. So we have a flow volume loop here, and we have a volume time curve. This is time in seconds. These are for the forced maneuver. So this is measuring the forced vital capacity. This is also the forced vital capacity on the x-axis. Y-axis for volume, x-axis for volume. This is a little indicator that this is the FEV1, and that is the indicator that this is an FEV1 at this point on the flow volume loop. This is expiratory flow going upwards and inspiratory flow going downwards, and in this set of PFTs, these black dots show you the expected value, the predicted value, which helps you see that this is a normal flow volume loop. The point of the graphics are two things: pattern recognition, the flow volume loop, it's really just there for pattern recognition, And secondly, for the pulmonologist, for the person interpreting the PFT, it is to check for the adequacy of the maneuver, to see if the maneuver was any good and should be interpreted. So one thing you might see, depending on your institution, is you could get a whole set of numbers, and then you could get an interpretation that says these maneuvers were not adequate for interpretation, in which case ignore all the numbers. They've come through because of the ridiculousness of software. If the interpretation says they're no good, believe it. They're probably no good. The next thing I do is I look at the FEV1 to FVC ratio to see if that is normal or if that suggests obstruction or diagnoses obstruction. Then I look at both the FEV1 and the FVC to see how close to normal they are. Spirometry it diagnoses obstruction, it can suggest restriction, or it can be normal. You need to look at the total lung capacity to diagnose restriction, and then the last thing I would look at is the DLCO. Okay, so we have some spirometry here. So we'll look at the graphics and we'll say, oh, that looks all right. That looks like a pretty sort of normal looking flow volume loop. Looks like a reasonable maneuver. Okay, now we can look at the numbers, we can look at the ratio, we can look at the rest of the spirometry. So my question to you, I'll give you a moment to think, and then we're going to use show of hands. That is the audience response system in this room now. I'm going to ask you to tell me which one of these you think it is. So just have a think. Okay, hands for obstruction. Hands for normal. Hands for possible restriction. Okay, cool. Great. On the learning edge, go on, advance my slide, please. Normal. Normal function. So the key here, what I'm trying to get at is we used to use percent predicted, we're now using z-scores. So this is actually an interesting set of spirometry that shows the problem with using percent predicted, because we said that 80 to 120% predicted was normal. You can forget that I said that, because what you should look at is the z-score, except that, of course, there's a whole bunch of institutions that aren't telling you the z-score. You know, they give you the PFTs and it might not have z-score on it yet. That's annoying. So the new thing is to use the z-score. Why do we use a z-score rather than percent predicted? We use that because, like so many physiological variables, lung function for a group of people of same height, age, and sex will follow a normal distribution, and the z-score is a statistical measure of how many standard deviations a given data point is from the mean of its data set. So the z-score is basically the same as the standard deviation, but it's for that specific value. This is what we've used for DEXs, for as long as I think we've done DEXs. Percent predicted is just a mathematical manipulation of the number, and it never made sense, but was easier to do. So the goal, of course, is to identify people with abnormal disease, and of course, there's going to be an overlap. There's going to be some people whose normal lung function is in this tail end of the normal distribution, and some people with disease whose abnormal lung function, it used to be up here, now it's down here, is overlapping with people who have normal lung function. So, like so many things, we use a binary approach, you know. We dichotomize lung function into normal and abnormal. We do that for so many things, and then we change what the cut point is, which just tells us that there's a lot more gray than we'd like to believe. And there's your gray, except it's blue in this. And so what are the cut points we're using? Helpfully, pulmonologists have decided to use a cut point of minus or plus 1.645. We chose not to use 2, which would have been easy to remember, because we wanted to be more sensitive for abnormality. And so we are using a 90% confidence interval around the mean rather than a 95% confidence interval around the mean. And so if we'd used standard deviation of -2, that would have got us to 95%. So minus and plus 1.645, often the z-score doesn't get presented to 3 decimal places, often it's only presented to 2, so really most of the time you're rounding up or down to minus 1.65. So returning to that original case. We're going to move on to another. So we look at our graphics and we say, looks like a reasonable maneuver. You'll note sometimes the inspiratory doesn't make it the full distance of the vital capacity. That's just a slightly bad maneuver. That's not a maneuver that we would throw out as not good enough. But you can imagine that this person, they were asked to take a deep breath in and then blow out as hard and fast as they can, and then breathe in again. And if on one of those breathe-ins or breathes out, they didn't do quite the same amount, that's how you end up with this graphical representation that doesn't quite come back to the same point on both ends. It's not a big deal. Okay, so take a look at this one, and we're going to do show of hands again in a little bit. Okay, show of hands for obstruction. Show of hands for normal. Show of hands for possible restriction. I will note that there's a lot of people abstaining from this game, which is a little disappointing to me, but all joking aside, this is good for your neurons. It's all about your neurons and your learning will be stronger if you commit. It's like, put your nickel down. You're used to that, aren't you? Okay, so normal function. Why did I use this as an example? I use this as an example because this individual's FE1 to FVC ratio is 0.65. Many of you may have been taught at some point that you were supposed to diagnose obstruction when the FEV1 to FVC ratio was less than 0.7, which this one is. But this individual, it turns out, in terms of a z-score, that is normal for this individual. That is because this person is on the older end of the spectrum of patients. And like so many things in life, our FEV1 to FVC ratio declines over time. So what I'm showing you here is that in young individuals, I'm showing you females because we often don't, but it's similar for men. The normal ratio, so the predicted would be here in the middle. This is, and the black line is the lower limit of normal, of the normal distribution for this group of people. So this group of people is going to be women of a certain height, whatever height, you can pick a height. And over time, when those women are young, the normal expected ratio would be up at like 0.85. And so you can imagine that if you waited for their FEV1 to FVC ratio to drop below 0.7, you're actually going to miss a whole bunch of young people who truly have obstruction. And so you would diagnose them as having obstruction if you use the lower limit of normal, if you use the z-score approach. On the other end of the spectrum are older patients and people. Because the FEV1 to FVC ratio declines with age, if we use a fixed cut point of 0.7, then we will over-diagnose obstruction in older individuals. And so using the lower limit of normal reduces false negatives and false positives. However, gold still advocates for the use of a fixed ratio of 0.7. The American Thoracic Society and the European Respiratory Society both advocate for the use of the lower limit of normal. Why on earth would gold say something else? Well, part of... I laugh because you could also look at their funding sources and think about whether that might affect anything, but separate from funding sources, one of their reasons is that they are trying to make a suggestion that can work for the whole world, including areas with low resources. And if you have a spirometer, then you can have somebody do spirometry, and you can look at their FEV1 to FVC ratio, and you don't need software that has the predicted values to tell you what the z-score is, and you can just use that cut point. So taking sort of a positive spin on this, maybe their reason for sticking with that fixed ratio is for low resource settings. The other side of things is that there's some data to suggest that using a fixed ratio still picks out people with symptoms. It would certainly be sensitive for older individuals, and GOLD is the Global Alliance Against Obstructive Lung Disease. They're really thinking about COPD, so they're not really thinking about young people. Okay, does this spirometry show a significant bronchodilator response? If you've been listening to me, you'll know the answer. Let's have a show of hands for yes. Okay, let's have a show of hands for no. Okay, so there's still people abstaining. So the answer is that this does show a positive, a significant bronchodilator response. That is because they changed the rules. Doesn't matter what the old rules are now, but I intentionally picked a set that might make that confusing. The new rules are, if the FEV1 or FVC has increased by 10% of the predicted value, so you would take the post-bronchodilator value of either the FEV1 or the FVC, and you would subtract the pre-bronchodilator value, and then you would divide that by the predicted value and multiply that by 100, and that will give you the percentage change. And if that is 10%, or if that is greater than 10%, then there is a significant response. And so the FEV1 here increased by 11%, which made the cut point. I thought I would use this as an opportunity to point out that in asthma, you would expect to see a positive bronchodilator response, and that post-bronchodilator, the FEV1 and FVC would be normal. So you'd expect to see full normalization. Some people with asthma might require more than just a couple puffs of albuterol to achieve that. They might require being on their inhaled corticosteroid for some period of time to achieve normalization. Whereas in COPD, we talk about seeing fixed obstruction. What do we mean by fixed obstruction? We mean that the FEV1 and FVC and the obstruction does not normalize after bronchodilator. So there is still obstruction present after bronchodilator. Somebody who has asthma can also have COPD through a variety of mechanisms, one of which could be if you have had asthma for some prolonged period of time with inadequate therapy, then you can get remodeling of the airways such that you no longer have just an inflammatory obstruction, but now you have truly fixed obstruction from increased smooth muscle hypertrophy and things like that. So you can have both COPD and asthma, but in asthma you expect post-bronchodilator to see normalization of PFTs, of spirometry. Next question. Which of the following diseases is this patient most likely to have? ALS, as in amyotrophic lateral sclerosis, also known as motor neuron disease, MND, COPD or IPF, standing for idiopathic pulmonary fibrosis, which is an ILD of unknown etiology, hence the idiopathic. Show of hands for ALS. Show of hands for COPD. Show of hands for IPF. Woo-woo! Everybody who voted was correct. That is because if we follow my suggested approach, our graphics actually kind of look like restriction. So we've got a peak flow that's meeting normal, but we are not getting a full, the vital capacity is not reaching expected. These are good maneuvers. They can be interpreted, and they were. And we can see that the FVC is below normal. The FEV1 is actually normal with a completely expected ratio. Although clearly I've done something a bit funny there. I'll fix that later. The TLC, however, is low, so this patient has restriction. The DLCO is also low, and so that suggests that it's a parenchymal cause of restriction. So we'll talk about restriction and lung volumes, which are of course created by the balance of the inward recoil of the lung parenchyma and the outward recoil of the chest wall. And when those forces are balanced, lung volumes are normal. If one force increases or decreases, the lung volumes change. I thought I'd fixed that, but I hadn't. So restriction is defined by a total lung capacity being less than the lower limit of normal. The cause could be that there's an increase in lung recoil, stiffening of the lung, and if that is the case, then you likely are looking at what might be termed an interstitial lung disease, or potentially might be termed a diffuse parenchymal lung disease. You would expect the DLCO to also be reduced in that situation. Or if you had decreased chest wall recoil, that could be because of some kind of structural chest wall abnormality. What do I mean by that? Kyphoscoliosis, some kind of surgery with perhaps plating of a couple ribs, or obesity, or weakness. In these situations, you would expect the DLCO to be close to normal. It might not be perfect, because if you squash the lungs enough, even if the lung tissue is perfect, it might not be able to participate in gas exchange to its expected value because it's just so squashed. So indeed, what we're seeing here is spirometry that suggests restriction, a TLC that is less than the lower limit of normal diagnosing restriction, and also a reduction in DLCO. So that suggests an interstitial lung disease. Next, question. So this is a set of questions. So take a look at this these set of PFTs, and then I'll ask you about the spirometry, and then I'll ask you about the TLC, and then I guess the name for this PFT is going to be a hard game to play. It's supposed to be a word cloud. Okay, spirometry, airflow obstruction, normal function, possible restriction. Oh, so many abstainers. What questions do you have? So the people who are abstaining, ask a question if something's not clear.
Are the dots like normal, or is that the patient's?
The dots are predicted. So that would be predicted, 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 predicted. Other questions? Great, I love that. You can also use numbers, yep. So this is possible restriction. The ratio is normal. These days, with a z-score, you can just look straight down the z-scores and say which ones are normal and which ones aren't. So the FEV1 to FVC ratio is within that minus to plus 1.65. The FEC and the FEV1 are both reduced, so this is suggestive of restriction. This is concerning for restriction. So now I need to look at the TLC. That, ooh, interesting. So the cut point would be minus 1.65. So this is sneaking in as normal. I'm actually giving you the answer to the next question. And that is a little sort of unexpected, except, of course, it's not anymore. So this is that non-specific pattern that I mentioned at the beginning. I'm bringing it up because it's not, probably wasn't taught when you were first taught about PFTs. And what is it? So it's defined as spirometry suggests restriction, but the TLC is normal. The definition sort of varies by paper and what have you, and often doesn't include DLCO. I would advocate that the DLCO should also be normal to really say this is a non-specific pattern. Of course, the term non-specific is not super helpful and has nothing to do with non-specific interstitial pneumonia, which is an interstitial lung disease. If the DLCO is abnormal, then I think you can think about things a little differently. When we see this non-specific pattern, depending on the study you look at, either what we see if we follow those people over time is somewhere between about a sixth and a third have obstruction on further PFTs, a sixth to a third, other way around, 6 to a third go on to develop true restriction, and somewhere between 2/3 and somewhere between a third and 2/3 have the non-specific pattern. I don't think remembering those numbers are the important thing. The point is that some people will just remain as having a non-specific pattern, but in some cases, this is hiding obstruction that we just didn't capture that day, or the beginning of a true restriction that just hasn't manifested itself on the TLC. To be clear, when we do PFTs, we get one snapshot in time, and the only way we know how that compares to someone's lung function before that is if we happen to have PFTs before that. We often don't. And so it may be the case that what we're seeing is somebody's lung function has actually dropped a lot, but they're still sneaking in as strictly normal. So PFTs are not the be-all and end-all. I didn't include a slide on this, and it's not what I've got on this slide, but I think it's really important to say they're just a screening tool and they're not that good. So please use all the data available to you when you're thinking about patients who, of course, from my perspective, most of my patients have either dyspnea or cough, or both. Please use all your data. Please get a chest radiograph. Please don't stop with PFTs. Please consider repeating them, going back to your patient, asking more questions again. I'm sure you do all of these things, but just want to make the point that we've got this whole session on PFTs and they're not that brilliant. Other terms you might see used similar to a non-specific pattern would be restrictive pattern spirometry or preserved ratio impaired spirometry. That's when we don't have lung volumes. And interestingly, no matter what the cause, people who have this kind of not completely normal PFT pattern have a higher mortality, and there's an association with a number of medical conditions. One of the possibilities for why somebody might have this pattern is that they are obese, and in fact the individual for this set of PFTs had a BMI of 46. And so often when I interpret a set of PFTs as having the non-specific pattern, I will suggest repeating PFTs in 1 to 3 years, because I'm wondering, does this patient actually have obstruction that wasn't manifest today? Do they have the beginning of an interstitial lung disease or some other cause of restriction that hasn't yet met full criteria? So I suggest repeat PFTs. In this instance, probably repeating the PFTs is not going to be super helpful. Okay. All right. We are moving on to talking about the wonders and perils of using race-neutral rather than race-specific PFTs. So we've got another example here, some spirometry. You can check out your Z-scores and tell me You can use a number. You could say, you could put your finger up like this for 1 or 2 or 3. And we keep waiting for more people to commit. Go on, just play the game. Okay, great. Yes, normal, indeed. That is what this spirometry shows. So I can tell you, the point of this was, so this is a 50-year-old man, they're 177 centimeters tall. They happen to identify as black. And so what I showed you there, I showed you the spirometry interpretation using the GLI 2012, GLI Global Lung Function Initiative, African American, using this African American equation, and it gave z-scores that were normal. If you use a race-neutral equation, such as the GLI 2022 Global, these are the z-scores, and so does that suggest obstruction, normal function, or possible restriction? Yeah. The equation used can change the interpretation from normal to abnormal, and in this case, to possible restriction. That's the most common change in interpretation. The equation used doesn't really affect the FEV1 to FVC ratio very much. That's quite similar, but it does change the predicted values for the FEV1 and the FVC. We don't have race-specific equations for lung volumes or DLCO. They're all kind of race neutral, not completely race neutral, but they're not specific. So, what are we to do? This is a conundrum. And where did this come from? Why do we see this? So we've talked about how PFTs will fall on a normal distribution, and historically race or ethnicity has also been included. And so this has been like, as soon as the spirometer was developed, which was in about 1850, people used it to do things like compare one population to another. So in the UK, one person took the spirometer, actually the person who developed it, and they looked at the lung function of like the nobility versus working class people. And guess what they found? A bunch of the working class people didn't have as good lung function, maybe because they were working in terrible conditions where they're exposed to awful things. And in the US, people who enslaved others had used the spirometer, and they found that their enslaved black individuals had lower lung function than free white individuals. And so there have been lots of studies of lung function performed in many different parts of the world, and they've resulted in lots of different equations that were developed, and there's like sort of controversy about, do you use an equation that's more specific for that population, or do you say we're all just humans, and so if the lung function of one population is lower than the lung function of another population, then is there something going on that we need to know about for that population? So GLI 2012, which is the was the largest and most recent attempt to standardize equations, they basically enlisted a whole bunch of PFT labs who had done studies with and developed their own equations. They pulled all of this data, and they initially had data from 33 countries, which sounds great, except that there are like 185 countries in the world, so it's not that great. There were whole swathes of the world that were just not included. For example, the Indian subcontinent, they had 5 data sets, but there was poor concordance, and so they couldn't derive reference equations, and so they just threw that all out. From a statistical perspective, that's the right thing to do. If we're truly trying to understand lung function, it's interesting to know the background. And so what they ended up doing was analyzing data from 70,000 or so individuals And you can see the breakdown. It was a predominantly Caucasian group. And from that, they used their statistical analysis and they found that the data for Caucasian, as defined by them as these data sets, or data sets from these areas, were concordant, and they created one equation for that. Then they developed an equation for African American individuals. They found that to be concordant. Southeast Asian and Northeast Asian, and that's it, which will also strike you as missing sort of great swathes of the world in terms of how do we describe all humans. So I'm going to jump a little bit to think about, like, why might we see some of these differences? Given that there is no evidence that the phenotypic features that are what we use to define race, so notably skin color and sort of shape of bone structure, particularly of the face, there's no evidence that that has a gene closely linked. That's also, it's derived from many different genes, but there's no closely linked gene that then gives you your lung function. So why might we see these differences between groups? Well, there are so many things that affect lung function. This is just a few for which there are very robust data. I think it is quite amazing to note that this includes prenatal exposures. And when we think about how these exposures affect lung function, they can affect lung function at any point in life. So in the absence of something that reduces lung function, we would expect to see this very sharp increase in lung function over childhood. A lot of that is related to growth, but also the lungs are still maturing in early childhood. In adolescence, this is mostly growth. And then, as I told you, unfortunately, lung function declines with age. And so depending on when somebody experiences an insult, that may mean that they can never reach their full expected lung function, or it may mean that their lung function gets brought down, having reached their full expected lung function. And so I would propose, and the ATS produced a white paper, a statement saying that we should use race-neutral equations, because when we use race-specific equations, we're basically accepting that race is the explanation for the differences in lung function between these groups, racial and ethnic groups, and we're not bothering to think about what the true causes might actually be. And so there are two options for race-neutral equations at the moment. One is the GLI 2012 Other, one is the GLI 2022 Global. The date, the year is the year it was developed. So 2012 used all of that data from GLI 2012, which you remember was mostly Caucasian. And so it's like a moderated Caucasian equation. Whereas GLI 2022 took the GLI 2012 data, so not new data, not different data, the same data, and used inverse weighting for each of those groups so that the four groups contribute equally to the predicted values. So it's a more balanced equation. So I'm now going to present a little data showing, in case you're not convinced, to show that I truly believe, and I think the data shows, that using race-neutral equations makes a lot of sense. Then I'll show you some of the problems with this. So here is a study looking at patients with COPD. We're looking at severity of COPD, so the FEV1 is getting worse as we go to the right on the x-axis here. And the patients have been separated, disaggregated into non-Hispanic, white, and African American, and you can see that for each level, each categorization of severity, we're looking here at severe respiratory events or exacerbations. They actually had graphs for, you name it, almost everything. Severity of symptoms, frequency of prednisone use, you name it. I just picked out one. They all looked the same. You can see that the red bar is much higher, i.e. for every severity of COPD, and this is using race-specific equations. For every level of severity, the African American people experienced more symptoms. It was like their disease was worse. If you then looked at this same data and you used a race-neutral equation to categorize severity, you would even this out quite a lot. I have to keep clicking the unable to establish Zoom connection button. So another study which didn't have a really attractive graphic, hence I've just written it out, looking at race-neutral versus race-specific equations shows that the race-neutral equations perform just as well. Because one of the concerns is that race-neutral equations won't perform as well. Turns out they do. They will predict mortality and hospitalizations just as well as race-specific equations. Now, to get into some more details, so here are more examples of why using a race-specific equation may disadvantage Black and Asian people. So these examples are for evaluating for restriction or therapies prescribed for reduced lung function. And so this top example here is the one that I was illustrating with that first set of spirometry, that if we use the Black reference or African American reference equation, this person's FVC comes out as normal. This paper was produced before we were using z-scores, but the z-score would be within normal, whereas the z-score would be lower and meet the criteria for possible restriction. Using a global equation, you end up somewhere in between. In the example, and so for this individual, if you used a global equation, you'd be more likely to continue the evaluation for possible restriction. And in evaluation for lung transplantation for an ILD, the FVC is the cut point that we use, and we use an FVC of less than 40% of predicted. And so again, depending on which equation you use, the same individual with the same FVC may or may not meet that cut point. Of course, just talking about PFTs is simplifying things. There are, of course, a lot more elements that go into decisions, such as whether or not you continue the evaluation of somebody for interstitial lung disease, whether or not you think about that person for lung transplantation. And in the case of lung transplantation, if the FVC at this point is 42% and they truly have a progressive disease that would benefit from lung transplantation, they're going to meet the cut point relatively soon. But still, you can see how the choice of equation could, on a population level, make quite a big difference. What I'm now going to show you is that another side to this discussion is that there are situations where using a race-neutral equation, which is what I've been advocating for. I've been suggesting that race-neutral equations are the thing we should be using. They may actually disadvantage certain groups of people. For example, they may disadvantage white people when evaluating for therapies that we prescribe specifically for reduced lung function. So here we've got an example of this man of this age, this height, with this FVC, and we're talking about using bi-level for nocturnal ventilatory support, for example, in ALS. And the cut point there for CMS criteria to pay for the bilevel is that the FVC needs to be less than 50% if predicted. Now, if this person has ALS, it will progress and they will meet this criteria. But I'm going to just give one last example. No, I'm not. There are more examples. I chose just to pick a few. It gets a little overwhelming. I'm going to come back to this case, which was the one we started with, and tell you a few things that you can think about, because this is a conundrum, like what is the right thing to use, and how do you even know what's going on? So when you get a PFT report, one equation will have been used, just one. It will tell you which equation was used up at the top of the PFT report, where it says the patient's name, MRN, date of birth, height, age, weight is also up there, and they will say what equation was used. And if you want to, you can go to this calculator, which is very easy to Google, GLI calculator. I don't think you need more than that. I think that will get it for you. And you can input that person's information. So you put in their age, their height, their sex, and then you can pick which equation to use. So you can pick Caucasian, African American, Northeast Asian, Southeast Asian, other, or global. And you can put in that individual's PFT numbers, their absolute values, and it will then tell you, for the equation that you've picked, what would be the predicted, the expected, and what would be the lower limit of normal, what would be the z-score, what would be the percent predicted. I would love for PFT software to make it easier to produce reports with two equations. But that is a lot of data. And then you're going to get these conflicting interpretations. But I think that in some situations that could really be helpful. So I have a few take-home points for you, and I'm happy to take questions. So the take-home points: z-scores are the way forward. They are statistically linked to the normal distribution. They're linked to the standard deviation as opposed to percent predicted, which was a silly choice in the first place because it's just a mathematical manipulation. Normal is from plus 1.645 to minus 1.645. Using the FEV1 to FVC, using the cut point of the lower limit of normal is more specific for obstruction than using a fixed ratio of 0.7. The criterion for a significant bronchodilator response is a greater than 10% change in either FEV1 or FVC. Restriction is defined by a TLC being less than the lower limit of normal. Spirometry can only suggest restriction. And the non-specific pattern is when spirometry suggests restriction, but TLC is within normal. And race-neutral equations make sense, but they don't always end up improving equity, unfortunately. And that was PFTs. Happy to take questions. I see a hand.
Yeah, I have questions about race-based equations in breast cancer. Because the indicator one of this was a gentleman who self-identified as African American. So that seems a little unscientific to identify somebody's race by what they say he identified as. You take
Yeah, yeah. I mean, great point. So the question was there, or the concern, the comment was around, how do we determine which equation are we going to use? And I described this individual and said that they identified as black, and then used that to say, well, this is a discussion about which equation. So, I mean, I will respond with a couple thoughts, one of which is intentionally a little bit inflammatory, which is, what is a better way? Quite frankly, it's a question, like, what is a better way? A lot of PFTs, the choice of equation is being chosen by the therapist or the technician who is performing the PFTs. I'm not sure that that's better. It's definitely not more scientific than the individual picking. There is some work around ancestry and how you could use some kind of a blood test to look at somebody's ancestry, not that we then have good equations to use, but sort of hypothetically, say we could have equations for all different forms of ancestry, then you could, sort of scientifically determine someone's ancestry and then choose the right equation. Of course, then you'd need people to be willing to have a blood test as part of getting a PFT, which is also problematic. I wonder whether I'm interested if it feels more acceptable to say, well, we're all humans, and so it makes sense to use race-neutral equations, or if you have any thoughts about a better way to think about how to determine race or ethnicity.
Well, I guess going back to the foundation of the question,
Yeah.
and of the formula was developed using populations that somehow were identified.
Yeah.
How were they identified? Were they identified as being by self-determination, by etc.? Somebody look at them and say,
Yeah.
this looks like this category. So foundation.
Mm-hmm.
I'm not even talking about how we use it, the equation. I'm talking about how the foundation that the test were developed, and what populations, how do they identify the populations, and define those populations when they develop the equation. And we just don't know, at least I certainly don't know.
Yeah. And it
What
would,
populations they use and what that actually means when they say we develop this equation using an African American or black population. What did that mean at the time they developed that equation?
and I don't have a good answer for you, and even reviewing the GLI 2012 paper wouldn't get the answer because one would need to go into all of the source data because they took all of the data. So you raise excellent points to which I don't have answers. I think Jason Dean earlier pointed out that there are lots of questions that are problematic and important and don't have clear-cut answers, and this is one of them. It's a really tricky situation. Yes, trying.
I think there was a patient that was earlier in the presentation where they had a BMI of upwards of 46 or so.
Yep.
With PFTs, is there any indication for doing PFTs while the patient is lying down? So I'm just thinking of like somebody with sleep apnea, obesity, hyperventilation, or just having like a very large amount of body happiness that can cause like intermittent obstructive pulses or things like that.
Yeah, interesting. So asking about when might doing PFTs lying down be helpful. We do spirometry upright and supine to help with the evaluation of diaphragmatic weakness. So our lung function generally is a little bit lower when we're lying down than when we're standing up, just the mechanics lying on our back. The mechanics are not quite so good. Interestingly, the mechanics might actually be their best if someone was on all fours, but I'm not sure people would want to do that in the PFT lab. the disease states that you mentioned, obesity, hyperventilation syndrome, and also thinking about obstructive sleep apnea, those are upper airway abnormalities that or related to upper airway. Obesity, hyperventilation, a lot of the pathophysiology comes from the obstructive sleep apnea, and that obstruction is not evident when somebody is awake and able to do PFTs, because you have to be awake to do PFTs. It only occurs when asleep. So you need to do the PFTs when they're asleep and lying down, which we can't do. So there is an indication to do spirometry when somebody is supine, and that is if you're thinking about evaluation for weakness, in particular diaphragmatic weakness. For those particular indications, spirometry would not be particularly useful to see that. Happy to take any more questions if anybody wants to come down to the front. Thank you so much.